Hi, everybody. My name is Jeremy Weiss. I'm the co-founder and CEO of Greenspace Health, and I'd like to welcome everybody today to another MBC educational session hosted by Greenspace. Before I get started introducing the webinar, and first and foremost, I want to take a moment to thank our panelists, Michael Johnson from CARF, Dr. Kimberly Gordon from iMind, and Dr. James Boswell from University at Albany for their partnership and efforts towards this webinar, which I think will provide a ton of value for attendees looking to better understand the clinical impact and application of measurement-based care, as well as how to prepare for CARF accreditation moving forward, specifically regarding measurement-based care. And of course, thank you to everybody in attendance for taking the time out of your day to learn more about MBC as well as CARF accreditation. As many of you know, at Greenspace Health, we are a leading provider of measurement-based care technology. And over the last 10 years, we've supported over 500 clinics, hospitals, payers, health systems implement measurement-based care to substantially improve their service quality, better understand outcomes, and inform quality improvement, ultimately ensuring that they have the process and data that they need to meet evolving accreditation and value-based care requirements. So just a bit of context setting for a second. When my co-founders and I first embarked on this journey, measurement-based care wasn't at the forefront of the conversation, and quite frankly, very few clinics were leveraging it. The evidence of its impact in research was profound, but its actual application in clinical practice 10 years ago was very low. Part of the reason for that was the immense burden and manual processes that were needed to implement. That's where Greenspace came in, and we set out to build a technology to make MBC easy to implement for clinicians and clinical leaders, and also ensure that the significant clinical value could actually be realized without the manual burden that had been necessary in the past. So now fast forward 10 years later, MBC has very much become a cornerstone of evidence-based behavioral healthcare, and it's moved from a nice to have to essential. And it's very much now recognized as a foundational component of evidence-based behavioral healthcare by national accrediting bodies, including CARF, who we're thrilled to have with us and hear from today. I'm very excited for this discussion. I'm always excited to learn from our panelists, but this group in particular, who are having and have had a profound impact on behavioral health service quality, and hopefully we can have this panel contribute to the growing momentum behind measurement-based care. A couple quick housekeeping items before we get started today. First off, if you have any questions during the webinar, please feel free to add them to the Q&A box at the bottom of your screen on Zoom. Please don't put them in the chat. They'll get lost in there. And once they're in the Q&A, we're going to be using the upvoting feature. So if you see a question you'd like to hear answered during the Q&A in the last part of the session, just simply give a thumbs up on the Q&A button, and that'll upvote it, and we'll make sure we answer the most upvoted and high demand questions. As well, at the end of the webinar, when you're exiting the Zoom, you'll be prompted to complete a quick survey. It'll take less than a minute to complete, and we'd really appreciate it if you provided some feedback on today's panel, as well as any suggestions you might have for future topics or sessions. Again, it'll take less than a minute to do. And now, without further ado, I'm thrilled to pass it to our expert panelists to introduce themselves and share why they're excited and looking forward to this discussion. So I'll get started with James first, and then Kim, and then Michael.
Thank you, Jeremy. I'm really excited to be here and discuss this topic. So I'm James Boswell. I'm an associate professor and the director of clinical training in the Department of Psychology at the University of Albany, State University of New York. And I've been doing work broadly in outcome monitoring, measurement-based care for about 20 years now, and have done this work in a variety of ways: measurement development, some implementation work, broadly very interested in practice-oriented research and how we can decide what measurement schemes are going to be most useful for particular sites and work with those sites to try to optimize outcomes at the patient and service level. So I'm excited about all different parts of the conversation and been really looking forward to the discussion. Thanks.
Hi, I'm Dr. Kimberly Gordon. I am a child and adolescent psychiatrist and transplant to Maryland, but a champion for measurement-based care at my organization, iMind. As a child and adolescent psychiatrist doing community work it's been really gratifying to use a centralized approach to communicate to clinicians about the importance of outcomes and data. I work in a historically marginalized community where there aren't any inpatient units available. And so, one of the things that's been really great about the work that we're doing is really coordinating care and communications across individuals from different backgrounds. My background has really been doing community work. So, some of the things that I do is work for the National Council, really kind of educating people around trauma informed care and culturally responsive care for individuals, and data is key to that. I have a various roles, so I can tell you a lot about myself, but I'm also assistant professor for Tulane University, which is where I'm originally from in New Orleans. So being an academic person, but also being someone who's been a community psychiatrist, I think what's really important is to really engage future generations around measurement-based care, how it can be useful, and really making them be experts in the field. So I'm just delighted to be here and sharing the conversation.
Hello, everyone. I'm Michael Johnson. I'm the Senior Managing Director for Behavioral Health at CARF. What that means is that I'm kind of the executive leader for all of the things behavioral health, OTP, and child and youth services for CARF International. I'm the one who's responsible for standards development and ongoing improvement in our systems around standards development. And I've worked in the field for 40 years. It's the only area that I've ever worked in is in the behavioral health space, both as a clinician, mid-level manager, and executive leader in a variety of community-based organizations. And so I'm thrilled to have the opportunity to be able to talk with you about our measurement-informed care standards and kind of how we got here and what our expectations are. So thanks for coming.
Perfect. Well, thank you everybody for the introductions. Before we start on the panel discussion questions, I want to just take a moment to clarify some of the terminology that you'll hear today. So terms like measurement-based care and measurement-informed care are often used in this space, and they can sometimes cause confusion. So while some believe that there are subtle differences between the two, in practice, there's no meaningful distinction. For the purposes of today's conversation, we'll use measurement-based care and measurement-informed care interchangeably. Fundamentally at their core, both refer to the same evidence-based approach, the systematic use of measurement tools and patient-reported outcome measures throughout the course of care to inform and improve the quality of behavioral health treatment. So let's get started on our first question today. And I will first direct this question at Michael, but I encourage everybody to jump in as you see fit. So Michael, measurement-based care is now widely recognized as a key element of evidence-based care. And national accrediting bodies like CARF are helping drive that momentum. Can you speak to why CARF prioritized MBC in its standards and what excites you most about the potential impact of this shift?
Yeah, Jeremy, it's something that as we just published it this year, it's something that we've been thinking about for a number of years. It's not something that we, just sort of, came to. I think that in your introduction, you were alluding to the fact that, there were sort of early adopters. There was some challenges maybe that organizations were facing, say a decade or so ago when we started really seriously contemplating creating a standard around this. We kind of feel like, this is a time where the folks have figured out ways to implement measurement-based care systems. There's a lot that still have not done that, but it's kind of at that tipping point where we feel like we need to jump in and to sort of push that implementation a little bit farther down the road than it already is. From a values perspective, one of the things that measurement-based care, or as the terminology that we're using in our standards, measurement-informed care does, is it really focuses on our core value as an organization, which is person-centered care, right? You can get to more granular impacts on an individual based on the use of standardized tools and instruments to be able to determine the impact and functioning that a person with mental health challenges might be experiencing. And so that aligns with what we value very much as an accrediting organization is to not just do programmatic based care, but really doing individualized care within the structure and foundation of programs. We think that it offers more objective data on the impacts on functioning that people have. And by doing that, it's also given the opportunity to teach the person served how to be able to utilize these tools and instruments even outside of sessions to be able to kind of self-monitor and self-correct, which we think is going to have a much more durable impact on the outcome of services. And sort of lastly around like, why do we do this is that CARF has, for all of its existence, had a number of standards around measuring outcomes and programmatic performance. And the implementation of a measurement-informed care structure very much facilitates and aligns with the need to be able to measure the outcomes for a population that's being served. You really can't get to meaningful assertions about the impact of care in a population unless you are collecting standardized, valid, objective sort of data from the population as we're going along. And then, when you ask what excites me about it is, I think that because of the reach that CARF has in terms of the number of organizations accredited, I think this is an opportunity to kind of kickstart and move the field a little bit faster, perhaps, than it has been going along. And I'm really excited about how there's going to be some intertwining between how do we satisfy these standards and leverage the types of technologies that are becoming more and more readily available to be able to improve the quality of care and service delivery, and perhaps even increase access to care going forward. So that's kind of the background and where we're at today.
Thanks, Michael. That's really helpful to hear your perspective. One of the things that resonated most with me of what you just shared is that the impetus for sort of focusing on this from CARF's perspective really seems to be, the focus is on the quality of services at its core. This is not just another item that's been put in to check the box. Like the rationale and thought behind this is, there's clear evidence that it leads to better care, and that's why we want to be encouraging it. Dr. Gordon, your team has been a long-standing clinical partner of GreenSpace with a strong MBC implementation. From an organizational lens, what initially drove your decision to adopt measurement-based care at IMI and Behavioral Health, and what were the goals you hoped to achieve, or the impact that you were hoping to see?
This is such a great question, and I'll start by saying that in working at IMI, one of the reasons why I decided to take on the position it was because they were already interested in measurement-based care. Many organizations that I've worked for in the past, there isn't really a great system in place to really collect data and understand what are the challenges working with certain patients. So oftentimes it leads to a level of frustration for providers, right? So, I looked for a place that was interested in really being a part of the future of medicine and psychiatry. But at IMI Behavioral Health, our decision to implement measurement-based care was driven, by three main factors. And those factors were heavily aligned to our mission to provide accessible, culturally responsive mental health care in a county who is in desperate need for more mental health services in Maryland. We recognize that our diverse population, for instance, required an approach to ensure that there was transparency in meeting, the unique needs of the clients, but also that the providers needed to have objective information readily available to them to make snap decisions. We have a mobile response team that's under the crisis continuum and urgent care, in addition to a stabilization team that's a part of the crisis continuum. I work with youth, for instance, in schools, and oftentimes our clinician will, reach out to us and say, hey, we have a kid that's in a school that's in crisis, and we ask them, hey, do you have any information about the youth? And because they're very busy, they may not have the opportunity to collect that information. But when you give them a screening tool, they say, yeah, I did get that ADHD scale, or I got that pediatric symptom checklist completed. So it's been really fortunate to have that information. We also wanted to enhance clients' engagement and empower them to be a part of the decision-making process, which was really important for us. So by implementing measurement-based care, we noticed that clients were more engaged and they were more interested in collaborating and fostering relationships with our treatment team and providers. This was especially important, again, working with clients who've historically been marginalized. We have a lot of immigrant, Hispanic, and African American clients, in addition to clients who are poor SES in the Caucasian and white communities. Thirdly, we thought about the culture of continuously engaging in quality improvement. Quality improvement is such a big, important part of the work we do. And our organization really wanted to significantly impact our community by giving information readily to folks who we report to, right? So, no one has to ask us, what are we doing? We can actually give them that information, and we can show progress over time and improvement of our clients, which has been great. Overall, our goal has really been to reduce hospitalizations, which is happening. Our rates are going down, enhancing client satisfaction and hearing them tell us that they're doing what we're doing, and also, again, supporting our CARF accreditation. But perhaps most importantly, we wanted to ensure that the voices of those that we serve are incorporated in our care process. Creating more equitable and responsive approaches was the way to do it. And as a supervisor, what I really love about this is that, if a client has a complaint, I can go look at their, assessments and measurements and say, if the clinician say, hey, there's a disconnect, I can almost sometimes see where the disconnect is. If you've been training people for a while, you kind of can get those little cheats along the way. So I've been really enjoying championing this for our organization. I hope I answered your question.
Yeah, you certainly did. And from my perspective, a lot of similar themes from other organizations who've been early adopters on measurement-based care. And the one point that particularly stood out is that empowered patients with visibility into how they're doing has led to more engaged patients. And I can say that across the board, it seems kind of obvious that would be the result when you're giving people visibility into how they're doing. But across the board, that is what we hear from many, many different organizations. Michael, back to you. With the release of CARF's 2025 standards manual, can you tell us about the key updates related to measurement-based care that organizations should be aware of and focusing on? And from a practical perspective, what does this shift mean for providers preparing for accreditation?
Yeah, so it's really, it's sort of one standard with multiple elements that we've introduced into our, for those of you who are familiar with our standards manual in section 2, which is our general program standard. So really, it branches across like all of the programs. I mean, outside of perhaps some things like prevention programs and things like that. So it's a standard that applies across all the areas in which we accredit. It is standard 2A12 for those of you keeping score at home. And it has 4 elements. It's saying that an organization has to implement measurement-informed care practices, and there's a few things that you're doing. First is you're using a standardized tool screen, so from a practical perspective, if you have not been in the measurement-based care space in the past, you're going to need to determine, what tools would be appropriate to use for your population. We talk about the tools being standard and standardized tools that are valid and reliable instruments that measure that it should be measuring and that the results are reliable, that you're thoughtful, kind of about that and making sure that you are using a tool that makes sense, that you're going to actually get meaningful and actionable information from to be able to perhaps focus on interventional strategies, treatment plans, et cetera. We are prescribing that the organization be collecting data at multiple intervals, right? So they're going to need to determine what are those intervals, and that's going to be driven by, again, the frequency of contact, perhaps, the population served, the reliability of the tool that you're using. So the organization is going to have to kind of think through and develop a program plan for that. We also have a standard that is asking, which I think is really meaningful, that both you and Kimberly have been talking about, which is we're prescribing that the results need to be shared with the person served, right? If we're not engaging the person in the results, then we're doing this for the record perhaps, but it's not going to have nearly the impact as when you're engaging the individual and helping them perhaps to show trending over time, right? They may not be feeling better, but they might actually be getting better, or vice versa. They may not be recognizing subtly that they're doing worse, and we need to interrupt that before it gets into a full-blown opportunity for hospitalization or something like that. And then, of course, the last element in that standard is around ensuring that staff have been trained in the process, right? So they're going to be trained on what those intervals are and have strategies about how to collect that at the appropriate intervals, that they have been trained in the interpretation of those results, right? And then what impact does that mean in terms of how they're going to perhaps learn how to tailor interventional strategies based on those results, right? So it's 4 elements, but there's a lot to it. And I think that for organizations that, again, starting from zero, this is a fairly significant organizational project, right? If you have not done anything around this before, starting from zero to trying to get something, if you've got a survey coming up in July or August, is probably a pretty big lift. I think that it should be a prioritized thing for an organization to begin thinking about how are we going to do this and start working on it relatively quickly. And then I would expect that you're going to have to look for opportunities to find technologies, whether that's yours or others that will be assisting. I think you have to be careful not to let perfect be the enemy of good, right? I think that sometimes people sit around and they become paralyzed because they haven't quite figured out the exact strategy, and so they do nothing. I think that it's important to start doing something, and even if you're not fully implemented at the time of a survey, be transparent with your survey team and say, here's where we're at. We've been working on this. Here's the decisions that we've made to this point. Here's what we begin testing, perhaps, those sorts of things, and show your plan, about here's what our next steps are going to be. Here's what our expected timelines are. We are not a regulator by nature, right? CARF is a quality improvement opportunity for organizations. You're not going to get shut down because you're missing an element like you might with licensing or perhaps some other entities. Our goal is to help you and to consult with you to get better over time. And after all, as we've said already a couple of times, but I think it bears repeating, the purpose of this is genuinely to improve quality and lead to better outcomes in care. And so that is going to be an ongoing approach. You're never going to be done implementing this system. There's going to always be opportunities for improvement. There may be new tools that come out that you may want to implement, and so on and so forth. So this is really a pathway to work towards this implementation over time, as opposed to just you're turning on the switch today and then everything is supposed to work elegantly.
That's really helpful, Michael. I think in hearing you articulate the standards, it's very clear that this is not data collection. That the tools must be meaningful and actionable, that they should be collected at multiple intervals, prescribing that patients have access to the results. That is the opposite of data collection. It's for a real, tangible, meaningful purpose. Dr. Boswell, I haven't forgotten about you. You bring a unique perspective on measurement-based care. Through both research and clinical training. You and your colleagues recently published the need for MBC professional practice guidelines. And for those less familiar with it, could you share the key takeaways specifically regarding how organizations should approach beginning an MBC implementation, and share why you believe that establishing professional guidelines is so vital for the future of MBC?
Sure, and what I'm about to say will sound very consistent with what's been said so far, but that particular work was part of an APA initiative, a particular advisory committee related to measurement-based care and this mental and behavioral health data registry. The registry was part of the work that was focused on selecting and advocating for the inclusion of the types of measures that Michael was just referencing, in particular for CMS's quality assessment and reporting initiatives. And so in our work with CMS and the registry, we were bumping up against what we would call the absence of measure-based care in the ways that's been described so far. That organizations and psychologists were collecting and reporting processes and outcome quality data. But for understandable reasons, it was pretty clear that they weren't collecting the information to support measurement-informed or measurement-based care, that it was more of a basic quality assessment or program evaluation function. And they weren't repeatedly administering measures. They weren't integrating the measure-based feedback into collaborative conversations with clients, and they really were kind of maximizing the measurement-based care tools that might be available. It's understandable why, obviously GreenSpace and other companies work to support that, because it's just very difficult to do. It can be a very heavy lift. But I think, just to echo the points that have made so far, I mean, the big focus of this guideline paper, and then subsequently what's been published by APA, it is this distinguishing between program evaluation and measurement-based care. So measurement-based care is a patient-focused or person-centric process, and the evidence is based on routine outcome monitoring and feedback that informs patient-level outcomes or decisions to begin with. And so the good news is, just that, like others have said, is that as you collect this patient-focused data, you can aggregate it up for other purposes and probably have more rigorous data and ways to test that and answer your questions. But because it's a patient-focused practice, it's critical for organizations to collaboratively arrive at a shared understanding of what information might be most useful to track for their patient population. And so, just as it's already been said, is that organizations need to take the long view if they really want to support successful implementation and sustainability, kind of approaching it with a couple of basic questions, like what progress and outcome information is going to be most relevant for the people we serve, what types of information, hopefully this is consistent, are going to be most useful for clinicians and other key decision makers within the organization. And once those are identified, then the task is to try to integrate the selected measurement scheme into the routine workflow so that there's a more seamless data collection and feedback process. And so it really does become part of consistent routine care. There's also research to show that clinicians need training and ongoing support to do this well, and in a way that's likely to maximize patient benefit. I think if we get to discussions about future directions, I think that's one area, certainly within the United States, where I could see a more targeted focus on integrating measurement-based care skills within a training program, say a graduate program. But regarding the establishment of guidelines, just as a general thing to do, this relates to our own and others' observation about measurement-based care adoption and the degree to which it takes place or doesn't. So, as we've already alluded to, there's confusion about what precisely measurement-based care entails, and so these professional guidelines of various sorts are a way to clarify what MBC means or does not mean. And they provide a structure and a set of principles that then set the standard for the profession and helps everyone start to swim in the same direction. And so setting these explicit guidelines is important also because it hopefully is going to guard against unhelpful practices. Sometimes I use this example that it would be very frustrating if I went to my primary care doctor's office for an exam and they took my blood pressure, but they didn't tell me what the number was, and they just took the cuff and they threw it in the trash bin. Like, that would be really weird, right? So if we approach this as a strict mandate about just monitoring outcomes without any clinically relevant guidance, then this is what some people will continue to use as so-called MBC, but they will fail to realize the benefits. And so, if I'm told just to regularly administer a measure, I do it, but I don't discuss it with the client. I don't explain the rationale for doing it in the first place. There's a danger in it not only being ineffective, but even potentially harmful when we think about alliance development and outcome and retention. So the guidelines we were proposing were more about sort of process implementation. What do we know from research and observation about best practices? And the goal is ultimately to set up principle-based standards for implementation to maximize benefit, but then also minimize the harm.
That's really helpful. I've got a follow-up question, but Dr. Gordon and Michael, anything you wanted to add to sort of how we're seeing that play out?
I think really well said. I think that the point that Dr. Boswell is making around really explaining to the person why we're doing this and how we're going to use these results and how we're going to share, sort of the responsibility of those results is really important, because otherwise it just feels like a data collection activity for the purposes of a record. And then it opens itself up to things like, people being dishonest, right? They're just going to Christmas tree the result, you know. They're not really going to take it as something that's meaningful, and then you lose the engagement opportunity that you have for improving satisfaction and strengthening the clinician client alliance. I think there are so many reasons that this needs to be done well, which is also again part of the reason why we're at this particular tipping point where it's like now feels like the time for us to codify this and to implement that in our standards, because there is enough diffusion of expertise. But I would encourage organizations to not just be trying to implement something to satisfy the standards, right? Because to Dr. Boswell's point, that could be harmful to people. You need to do it in a well thought out way that is with staff that are trained, that interpret the results effectively, and that they are able to engage that person in ways that's going to be helpful for them and their outcomes, not just to say to a CARF surveyor when they walk in the door, here's our information that satisfies your standard. That's the fear that that I've had prior to us getting to this point today.
I want to add something, and I think the comments were well stated. One thing that I think I'll be a little anecdotal, but I want to highlight just the importance for our workforce development. Oftentimes, for instance, I'm in behavioral health, and the integration of many providers, all with different skill sets and training abilities and capabilities. Oftentimes, the mental health literacy, even with your providers, are different across the continuum of care, right? And so, how can we have a unified, codified way to communicate what standards are, what evidence base is? Oftentimes, I remember when I was in training over 20 years ago, we work with psychologists and child psychiatry because that's kind of what we do. And I remember how well the psychology's trainees had understood measurement-based care in comparison to the medical providers, right? I think that's changed a little bit. But one thing I valued in my supervision was my supervisor sitting down with me and let's go over these scales. Let's interpret what these mean. And let's talk about what your relationship is with your client, right? And oftentimes I would go back and I was like, I missed something, right? So not only is it improving the mental health literacy for the client and really helping us gauge their symptoms and their progress over time and noticing if there's any deterioration, but it's actually gauging how well suited our providers are in providing care, right? Like what needs that they may still have and how to support them in really acquiring the skill sets that's needed. And again, with the mental health workforce shortages that we have today, sometimes we don't have enough time to really pull out a piece of paper and, a PowerPoint and have a discussion about, autism or whatever, but you can pull out a scale and really start thinking about the diagnostic criteria that's involved, why they ask the questions that they ask. And it's just been transformative for people in the mental health profession in general, just to have that extra resource that's readily available. So I hope that highlights a little bit why I think it's so important. And we've overcome a lot in the last 2 decades around data collection. Now you don't have to have the paper and the pencil and try to interpret and read what the instructions are. I mean, GreenSpace can tell you all of that in one button, right? So why would you hesitate to get something set up like that for the community that you serve so that everyone is on the same page about how we're really doing?
Yeah, really, really great commentary. I appreciate everybody's thoughts on that. And back to Dr. Boswell, in one of our past conversations, you shared a thoughtful perspective on the role of measurement-based care in clinical decision-making, not as a directive tool, but as a valuable input that helps guide collaborative care. Candidly, a common concern people have of measurement-based care is that it'll be used to direct treatment decisions solely based on data inputs. We know that that's not the intention of measurement-based care, and that it's really intended to drive more informed and nuanced treatment decisions. That said, could you speak to how measurement-based care helps support and enhance care decisions and discussions rather than replacing clinical judgment, and why that distinction is so important?
Sure. And it touches on just the complexity of this being a skill, that needs to be learned. There's variability in the skill and how do you use it to automate your clinical judgment. But I think that just as plucking an evidence-based treatment manual off the shelf is never going to guarantee a positive outcome for a particular client. Measurement-based care needs to be considered part of a broader evidence-based practice process, that integrates clinical judgment, individual differences, and preferences. This is very much related, to, even though we're using them synonymously, discussions about whether or not, is there a difference between measurement-informed care versus based care? If measurement-based care seems like it's going to be a bit prescriptive. But interestingly, notably, nearly, if not all, experimental investigations of measurement-based care in behavioral health can be thought of as additive design trials. So these are comparing routine treatment based on clinical judgment alone with routine treatment plus some sort of measurement-based care feedback intervention. So it's all of what we know about measurement-based care is essentially a test of augmenting clinical judgment, which ideally is going to include collaboration with one's client. So setting that aside, most MBC tools are outcome focused. They track relevant symptoms and functioning domains. They don't need to be. They could be more process focused, but most of the research has been on outcome focused. And so when predictive analytics are applied in automated feedback systems like we've talked about so far, you can learn if a client's on track or not for a positive or negative outcome. If things are on track, then that's great. And that gives me some indication that I can stay the course or maybe even consider discussing termination with a client. But if things aren't on track, most feedback systems aren't, even the most sophisticated available, aren't going to tell me exactly what to do next. There's a signal that I need to consider potentially doing something different. And I might need to revisit my understanding of the problem. I might need to revisit my treatment plan, my technical approach, again, in collaboration with the client. There are systems that supplement the outcome analytics with decision support tools that will direct you to additional assessment to try to home in on what might be stalling the progress. Is this an alliance quality issue, as an example? But even with these, they're generating clinical hypotheses, that the clinician then needs to consider and then test themselves with the client. So measurement-based care is always a tool. It's really nothing more than that. It provides a signal, and as a mental health care specialist, my job is then to try to translate that signal from that evidence-based tool into something that's personally relevant and helpful to this particular patient, which may be very different for another patient. I think it would be great if all of our clients experience this linear, steady, positive improvement. But when things go off track, these are opportunities for professional creativity. I don't really see it as prescriptive at all. I like to think about George Stryker's concept of the local clinical scientist, where you are conducting N of one sorts of studies with your client. And this is where kind of our responsive patient-centered clinical judgment is really going to be put to the test. So I don't think it's ultimately prescriptive. And I think even if we wanted it to be, we're not at the point as a field to be able to be totally prescriptive about what to do with the data as it's coming.
That's a really helpful perspective. I hear the theoretical fear about it being prescriptive. In practice, it's not what we see. We had a great discussion in past panels with Dr. David Clark, who leads the largest global implementation of measurement-based care through NHS talking therapies in the UK. And one of the pieces of advice that he gave, which I think is relevant to this, is that if you're hesitant as a clinician, just get started and give it a shot. Because what they saw is that after a clinician starts using it, they realize the value, they realize it's not prescriptive, and more often than not, just don't look back. Being mindful of time, because we've got some really great questions in the Q&A. We might have time for one, maybe two more for the panel off my list. Back to Michael. As organizations prepare for their next CARF accreditation process, what's your biggest piece of advice to them to keep top of mind when it comes to meeting your measurement-based care requirements?
I think I I certainly addressed some of it, right? And I think it's about, getting started, setting it as an organizational priority if you're not already in that space, and begin to do the work, and not worry about trying to do it perfectly, right? I think that it's I'm hopeful that our surveyors are also going to be helpful in the process. If organizations are struggling, that they'll be able to share some thoughts and insight into how to effectively implement the system that the organization is trying to implement. I think if you are already you already have a system in place, if you're like an iMind at your next survey, you would think that everything's going to be ready to go. But I would certainly want to encourage those organizations also to take a look at their systems, right? And be prepared to make sure that all of those elements are being covered, because I think the thing that was jumping out in my mind when Dr. Boswell was talking is that although there is certainly that fear about the prescriptive nature, and there's not probably a rational basis for that. I think one of the things that is real is it is going to challenge the clinician to figure out what to do, and it's going to challenge the clinical supervision in the system, right? Because now it's like I have, instead of just my opinion, I have some real data that's telling me that this person is not doing well, perhaps, and I'm at a loss to know what to do next. And I think that that's going to be the interesting bit, is to make sure that the training of clinicians is aligned with what it is and what to do about the results.
Thanks, Michael. I think we'll switch into the Q&A. There's a lot of really good questions. And the first one, any of the panel should feel free to take it, but maybe Dr. Gordon, this one's most closely directed to you. The first one was, I'm curious to know how you're involving clients, youth in particular, in the measurement-based care process. Specific examples would be great.
That's a great question. And I'll say, initially I was a little bit hesitant as someone who's working on the crisis continuum, because again, we see people in an initial urgent situation, and oftentimes asking them to do something more is challenging, right? Like, can you do this information? So one of the things we decided to do was to develop a script around what is measurement and why we think it's important. Because again, people need to hear why we value this and what we think the value will be for them. So in our lunch, like really across the continuum of our care, including outpatient, we decided to have a universal approach, right? So all of our clients get some of the same information all the time. And so if they're in an outpatient clinic, they hear the same thing that they hear if they're interfacing with us due to a 988 call or some crisis hotline intervention. But I think the most challenging part really has been incentivizing clients to complete them on time and do them often. So they may do the initial, but they don't do the follow-up, right? And you really want to get data across time. You don't want to have that baseline, but not have like all of the information. And so what we've been doing is incentivizing people through a grant program, but incentivizing people by giving them a gift card, particularly for youth, because they get busy and they don't really want to do it. And, you have to remind them. But if you say, hey, you're coming to treatment, you're seeing the improvement, why don't you reward yourself for that? And so that's been really nice to do. Obviously, there are some ethical considerations and things that you want to do to make sure that people aren't doing that just to get, money and feel like obligated. But I think, having your processes in place, attestation forms, and the reason for that really drives clinical engagement. What we have noticed is now kids are asking for it. Hey, can you give me that form? Because I got something I got to say about this, whatever. So sometimes I hate to say it, some of my kids say, I'm getting them told because this provider is not doing what they need to do. And I want to, and the screening tools are not really about that, but you can just see how a person is invested in their treatment in the decision-making process when they have something that they can put on paper and say. We also have client satisfaction surveys that we link and tag with our assessments and measurements. And so what happened is some people may say, I really don't want to complete that measurement, but I'm going to do that satisfaction survey this time, which I think is interesting and it tells you some information too. So it's been really rewarding to think about how to support a certain population, for instance, young folks, and engaging them and also their parents.
Thanks, Dr. Gording. Another good one, probably directed at Michael. How are the new CARF standards related to measurement-informed care different than previous ones?
So the measurement-informed care standard itself is brand new for 2025. It did not exist before. Now, there were standards in our Aspired Excellence and our business practice standards that talked about performance measurement and management. That is really was looking at programmatic outcomes, right? Looking at measuring the performance of a program and improving quality. And so I think that people might think that they were the same thing. And I look at them as they're aligned standards. They are not exclusive to one another. You probably always should have been implementing some sort of measurement-based care activities, at least on the measurement side, even if you weren't utilizing it for actual service delivery. This is trying to mature that whole system, that we're going to both improve the quality and measurement and engagement of the individual, and hopefully responding to their individual needs, while also using that data to be able to make determinations about the performance of the program, and even looking at things like clinician differences, right? You might, if you're using standardized scales with a similar population, you might see variances from one staff person to another. There may be opportunities to be able to generalize learning throughout a group of staff. Why is it that your people seem to get better faster? What kinds of interventions are you using? Is there something about you that's different? I think it's going to lead to a whole lot of opportunities, but the standards around that 2A12, that measurement-informed care standards, and these discrete activities are brand new and did not exist before.
Thanks, Michael. Another really good question, and anybody feel free to jump in, but maybe Dr. Boswell, this is a good one for you. Do you have any suggestions on how non-clinical evaluators can encourage clinicians to use and document measurement-based care assessments when they're often seen as an administrative burden? I understand the intent is to help them make better treatment decisions, but that framing is difficult coming from a non-clinical champion of measurement-based care.
Trying to think of what is meant by a non-clinical evaluator. Are we thinking about an administrator, like how an administrator motivates people to do this?
I think that's part of the question. So it's somebody who is not providing clinical services and maybe doesn't come from that background.
Yeah. Well, hopefully this will at least indirectly answer the question. I mean, I think it does. It does come down to treating this as a long-term process that requires collaboration among multiple individuals. I mean, I think it's totally understandable if a clinician's frustrated and finds it onerous if you're asking them to use a tool that doesn't seem relevant to their work. We've also done projects with community clinicians where they were co-developed with non-researchers. So these are primary practitioners, and it's a practice research network / community participatory research kind of model, and we'll work for 6 months to identify the construct that we're interested in and what measures exist out there that might be relevant for measuring it. But then we start the project, and 3 months in, somebody might say, like, I don't know that I like this measure. And we have to have the discussion about, well, maybe it's a little bit too late because we already started collecting data, but the next time we can do something different. But I think that actually listening to clinicians who know their clients best in many ways. I mean, I think in taking their perspective seriously and landing on a measurement approach that is meeting the standards that we've talked about, but is also determined to be very clinically relevant to their work. And I think that goes a long way. We've also found, and then I'll just say anecdotally, that anecdote also goes a long way, that clinicians who are skeptical, we've done some implementation work and just starting to do the work and then bringing in examples about how it was used with the client. We didn't pick this up initially, but we kept administering the measure, bringing it into session, and then suddenly this domain spiked, and the client wasn't going to bring it up otherwise, but it showed up on the feedback report, and so we talked about it, and it turned out to be really important. like these sorts of conversations, like having respected colleagues describe examples of how, like, I was skeptical, but I used it this way and it seemed to actually be beneficial. I think that helps. I mean, I don't think, again, and sorry, I'm rambling now, but I don't think you have to be an expert in order to facilitate that process. You know, I think you can be open to having these discussions with clinicians and you know, sort of trusting their expertise about their own work at some level.
That's a good answer. I appreciate the detail there. A question directly for Dr. Gordon. I have found many psychiatrists are not as excited about measurement-based care as you are. Can you give advice on what would get more psychiatrists interested in measurement-based care?
Oh, my community. I would argue that psychiatrists, we are so few that it's not that we're not excited, but we oftentimes feel the administrative burden of being in multiple places at one time. And so I think the value of, having something like green space is that you really can make your life easier. I want to go circle back to James' question, the question that was directed to James, and then talk about some of the benefits that maybe psychiatrists don't see oftentimes. So let's say, for instance, you really want to see some improvement with your client's engagement, and you notice that a certain clinician is doing well. Many psychiatrists are in leadership roles, even if they're not the medical director or the CEO. Oftentimes, they're engaging with their other peers around clinical care and making it a little frustrated because oftentimes psychiatrists are seen simply as the prescriber, right? You're just prescribing, just stay in your lane, don't ask any questions. But the value of an instrument like this is that you get to communicate with folks who are doing therapy and other work differently. You can pull out that tool and you can say, hey, I get you. Like, you're the therapist, but my patient is communicating something to me that I want you to know about, right? And everybody is interested in their client's improvement, right? So what I've been doing is in my supervision meetings with, peer support specialists, social workers, psychologists, nurse practitioners, as I go into green space and I open up the screen and I say, hey, this is how our providers are doing in terms of implementing green space. Look at how many clients you've seen that do this, and sometimes it's 100%, sometimes it's 75%, sometimes people are 0%, to be quite honest. And then I open up a subjective thing that one of the clients may have stated about, how they're improving. And you can see how people light up and say, wow, I didn't even know, that was there. I would just say for administrators, don't just ask people to do work, but go back and look at the results yourself and look who's actually doing that and incentivize them and champion them and tell them how great a job they are doing it. I don't know if to answer the questions in terms of like how psychiatrists may not be using it, but I think oftentimes it's really a collaborative relationship and conversation that needs to be had about the value more so than a value of not doing it or not, right? Another thing to think about is someone asked the question about cultural responsive care and whether or not some of these instruments are, responsive to that. I believe in cultural adaptation. So again, because we all are trained the same way and we kind of speak the same language, our clients don't. They don't know any of that. They don't even care about that. So you can take that instrument and you can say, how would you say that? How would the people in your life say that? And it opens up a whole nother dialogue and you can adapt it with the conversations that you're, having with your clients. But there are some really great instruments that's available, particularly for social determinants of health or ACEs. I have a scale that I use that's around student well-being. There's a student well-being questionnaire, in addition to one that's about parent hassles. So kids get to say how much their parents get on their nerves, right? And why they get on nerve and what kind of issues they're having with their parents. So those things are universal. And I think that as we use like universal tools, but adapt it to the language that people are using, you just get a better outcome in general. I hope to answer the question about psychiatrists, but I mean, I know a lot of psychiatrists who use it in their training, but then after their training, they're just like back-to-back 15-minute appointment med checks. And then it feels like a burden. But it doesn't feel like a burden if you're meeting a team, you're meeting with teams and you're talking about it in those team meetings. So that may be a way for you to just champion that you are reading that before you do your med management appointment. And then it gives you another thing to talk about in the team meetings, right? So that's my answer.
Thanks, Dr. Gordon. And not to go back to you straight away, but there's a bunch of questions around EHRs. Did you try to use your EHR to do measurement-based care first?
Yeah, we did have some instruments that was in sync. That's what we use. We had the PHQ-9 CRAF, which is a instrument that we use for substance use disorder, and I believe there were some others. I just can't remember their names offhand. It was useful for getting information about the clients, but it was harder to aggregate and look at that information and really explain the data as it related to our grant. And we got like a lot more requirements in reporting, and we needed something that was faster and more equipped to do that type of work. So I think if you're starting out and you're like, we have EHR, we can embed some of those things in there, and you just want, your providers to start engaging more with, these type of measurements. I think that's really important. But if you really want to see really quickly how all of that information matters, I think you really do want to get a more sophisticated system where you can kind of look at it. I love the analyzation page of GreenSpace. I'm like, oh, let me analyze this. Let me just pull this screen up and just see what that means. And sometimes I could spend hours with it. I'm like, oh, what happened with the time? But I think it's a useful way. Many EHRs don't just have those features in place. And that's the reason why we decided to go with GreenSpace.
That's helpful. Look, I'm obviously biased, but so much of the theme here today has been we're not just collecting data. We need to empower clinicians, clients, administrators, supervisors to actually use that data. So whatever system you use, I think you got to feel confident that the data is actually going to be used for the benefit of the client and focusing on outcomes. I wish we could answer all the questions. There's a lot of really good ones, but we're almost up against time, so we do need to wrap up. It's pretty clear that measurement-based care isn't an ideal anymore. Things have definitely changed, and it's become an essential part of delivering high-quality behavioral health services. This is exciting because it didn't start because funders or accreditors demanded it. It started because organizations chose this path. They were excited about improving care, saw firsthand the clinical value that measurement-based care brought to their services, better outcomes, stronger client engagement, more informed, efficient, and effective care. And now, funders and accreditors are expecting it, and it's become a widespread standard. But the heart of measurement-based care fundamentally remains the same, which is what we talked about today. It's about providing better quality of care to the people who need it, and holding ourselves, our industry, to the same standard as other areas in medicine where data is core into the delivery of care. So from my perspective, we're definitely at a turning point, and over the next 5 to 10 years, we're going to see real transformation thanks to the changes that are happening today around measurement-based care, and not just in systems and policies, but the quality of care that people are receiving every day. So I really want to thank our panelists for being here today. It has truly been a pleasure to host this session. You guys have made my job really easy, and really an incredible group of experts. And I appreciate the lessons learned and sort of the real life examples that everyone has shared. And thank you again to everybody else who attended today and to take the time out of your busy schedules to be here with us. As always, if you're considering implementing measurement-based care within your organization or system, or you have any questions about the process or measurement-based care more generally, feel free to reach out to us anytime. And then in terms of what comes next, stay tuned. We'll announce our next educational session soon and hope to see you there. So thanks again, everybody. Hope everybody has a great rest of the day.